Pleasant morning, everyone. Pleasant good day. Whatever time you're watching this video, I hope that you are well. Today we'll be talking about measures of occurrence, and this is another session in epidemiology, EPI 4002. Measures of occurrence. What do we think about? What comes to mind when we think about measures of occurrence? We're really talking about the diseases that we experience and the deaths that we may experience and how we measure that. How do we represent that statistically to make sense, to be able to make decisions? So the measures of occurrence really speaks to the mortality and morbidity rates that we would present to provide information to the public. What will be our objectives for today? Upon completion of this lesson, all students should be able to differentiate between the terms incidence and prevalence, assess the relationship between morbidity and mortality data, be able to calculate with a 100%, of course, proportionate mortality, infant mortality, maternal mortality, among other rates, and to judge the relevance of adjusted rates from specific epidemiological data, as well as to describe at least two methods for presentation as it relates to epidemiological data. I just want to remind you of these terminologies. We would have discussed them before as it relates to distribution and determinants, proportion and rates, incidence and prevalence. As it relates to distribution and determinants, we're really speaking to rates and frequencies. We're talking about factors and events and characteristics that we would see or be able to use to say the how or the why a condition is occurring. In terms of the proportion or rates, we are really quantifying diseases. So in terms of the measures of occurrence, it's really a way to present a quantitative representation of the data, of the findings that we would have had, the number of deaths, the number of illnesses as it relates to any particular illness. We're looking at relationships in population. So is it that we have a large population and therefore we're having this particular illness, especially if it's something that is contagious, or is it because of lifestyle? So we're looking at the relationship between illnesses and the outcomes. And as it relates to incidence and prevalence, we're really seeking to know how many new cases we're having as it relates to the incidence, and also how many persons, what's the burden of the disease in the population at this time. And we're really using that to help us, again, to plan and to make assessments and to make judgments as to how we go about managing and controlling various diseases. Incidence rates, and by further explanation of that, it's the total number of new cases in a disease in a particular population. Note that when we speak to this, we are looking at a particular period of time. And why that is so is that after a while, you have a disease, you're no longer considered as an incident case, but now you would be now in a different grouping, which would be known as the prevalence. So the time in which this occurs or the measure is done is critical to really providing that true or information related to how many new cases would have developed in that period of time. So what is the impact of this? We do know that there are some conditions or diseases that are highly contagious that could lead to death. So we want to know within a period of time, how many persons would have had. If it is for example, a virulent virus, we want to know how many persons have, and so we can predict maybe how many persons will develop the disease over a period of time for fast action and for also being able to stem the disease or the condition at a quick time. We also have self-limiting diseases. So while they may be contagious, for example, viral meningitis, these diseases or conditions, they are self-limiting, and therefore the action that needs to be taken may be less vigorous as opposed to a bacterial meningitis that is very deadly if not treated with much expedition. We also need to know about incident rates because we want to know how many persons in our population can be vaccinated or is vaccinated against the illness that we are assessing. We look at herd immunity in that context where we have a certain number of persons in the population that is enough to prevent an epidemic or a pandemic from occurring. So if we have herd immunity, it means that there's a certain proportion of persons in the population who is already vaccinated, whether it's by natural processes in that you would have had the disease and therefore you're not able to develop the disease, or you were vaccinated in that you're given an injection to prevent the development of the disease. So in terms of vaccination, we're really using that to cure, especially non-contagious diseases. But we do have some contagious diseases that we do have vaccinations for. For example, COVID-19 is contagious, and we do have vaccines for that. Another phenomenon we could look at is the prevalence, which is the proportion of cases in this particular population. And we have varying ways as to how we can measure prevalence. We have point prevalence, where we're looking at this particular time, how many persons do have this condition. Or we may have a period prevalence where we're looking over a period of time, how many persons develop this disease. While incidence would maybe give you a more specific time of development as opposed to prevalence, we use prevalence really to estimate the probability or the risk of persons being infected or developing the particular illness. So here is a picture or a diagram depicting the prevalence, how it occurs, what happens, how it is impacting the population, what happens if we don't have anyone dying or if we have persons dying. And this is purported by Gertzman in the textbook that he would have written on epidemiology, where we see we have new cases coming in, and these are joining the old cases, which of course would increase the prevalence. So if we have new cases, then we see that, and this is mirroring a cistern, of course, we're having an inflow. So in this case, it probably would have been water. So we're having an inflow of water in the cistern. If the faucet on the cistern is closed, then all the new cases remain and all the old cases remain. That would therefore increase the prevalence of the water or the amount of water in this cistern. And if we are mirroring a disease, then it would increase the number of persons who are having the disease. Outside of persons recovering or dying, then this cistern of would increase, or the number of persons in the population continues to increase. And we're seeing that especially now with our chronic illnesses, where persons are living longer with chronic diseases. So we have a greater or higher prevalence of these conditions when we compare that to maybe 50 years ago. However, if at some point in time, or if it's a self-limiting disease, or if it is a disease that can be cured and persons recover from the illness, then we will find that the prevalence will decrease. Also, if persons die, then we will also find that the prevalence can decrease. All right. So ways in which we can increase the prevalence is that if we are increasing the number of new cases of the particular disease. or if the persons who are developing the disease are living longer with the disease and not being cured from the disease. So those are two critical reasons or points to note why we can have an increase in the prevalence of a particular illness. All right, so diagram just is indicating just how some key points as it relates to disease prevalence and incidence. So the activity that I'd want you to perform now is to identify two factors that reduce prevalence and also differentiate between prevalence and incidence. You can pause and write your responses. Okay, so these factors we would see here listed can either increase the prevalence or decrease the prevalence. So the longer persons live with the disease, if life progresses and there's no cure for the disease, if we have a number of new cases or the incidence increases, of course, then the prevalence will also increase. If there are persons who are ill with that particular disease that we're looking at and they enter your population, so we have an increased number of migrants in your population with that illness, of course, again, the prevalence can increase. If we have out migration of healthy persons, so if it is that we have 10,000 persons and say 200 of those persons are healthy persons and they leave the population, then the ratio between healthy and unhealthy decreases, and hence the prevalence would increase. Also, if we have in-migration of susceptible persons, so persons who are coming into your population and they are possibly at risk for developing this particular illness, you can find that the incidence would increase as well as the prevalence. And of course, we see improved diagnostic facilities. If we're able to identify at a greater rate or faster rate number of persons with the illness, you will see over time that the prevalence will also increase, especially if it is not a condition that is either self-limiting or can be cured. Other factors that can affect prevalence, and here now they are decreasing the prevalence rate in a particular population, are shorter duration of the disease. So if it is that you develop a condition, for example, if you have the common cold, or if you develop influenza, or maybe a bacterial infection, say for example, it could be a yeast infection or something that has a short life, it can be cured, then the prevalence would decrease. If we have a high case fatality rate from the disease, so if it is that persons develop the disease and they die, then of course you'd have less of those persons in the population, and hence the prevalence of the disease would decrease. While the death rates from this disease would increase, the prevalence, meaning the number of persons still within that population, would decrease. If we have decreased new cases, of course, that goes without saying that, of course, our prevalence would decrease. In migration of healthy people, so your population that you're comparing your diseased persons to would be greater, and hence the prevalence decreases. So for example, if you had 10 persons in a population with a particular illness and the population at this point in time is 1,000, then we can calculate the percentage there. If it is that our population increases from 1,000 or 10,000 to 500,000, then of course the ratio of disease to non-disease is decreased, and hence the prevalence also decreases. On migration of cases, so if you have persons who have the disease leave your population, of course you would see a decrease in the prevalence there. And lastly here, improve cure rate of the cases. So if more persons are healed or recovered, it indicates that the prevalence would reduce. I want you to think about how does improving the diagnosis of the particular illness or having better facilities to carry out your diagnostic actions, how would that impact prevalence? Would it increase only, or would you see some decrease over time? That you can share with me in the comments. All right, mortality or morbidity. As we look at the health of our population and we recognize that public health and epidemiology really has a focus on the population, we look therefore at what are the conditions, the diseases, the programs that can be implemented to reduce mortality and to reduce morbidity in our population. So we're looking at not just an individual, but we're looking more so at the general population. So when we think about prevalence and incidence, we're looking at morbidity and we're looking at those who are ill in the population. While we look at that and we recognize that the more severe a disease is, and especially if it is contagious without a cure, then of course we're going to have more persons with the particular disease. We got an example, and maybe 10, 15 years ago, we probably would have been more scared or more attentive. For example, HIV/AIDS, we do know that at this point we still do not have a cure. Nonetheless, we have many measures that we use to prevent the infection of HIV, as well as we have several drugs on our market that we use to reduce the spread of the disease in a context in that it reduces the viral load in individuals, but also in terms of educational programs that would have been integrated in the treatment and the management of the disease. We're having less persons developing the disease, and therefore, over time, the incidence as well as the prevalence of this disease is reducing. So public health interventions often aim to reduce both morbidity and mortality. If we can reduce morbidity, of course, we are therefore able to reduce mortality. So in terms of mortality, and that's death, we do measure what happens in the population. And there are three main types of rates that we measure. We measure crude rates, we measure specific rates, and these examples of specific rates may be age-specific rates, sex-specific rates. We could have also infant mortality rate that's considered to be a specific rate. And then the third type of rate would be the adjusted rates. So here's an activity for you. There's the infant mortality rate, there's a calculation, the proportionate mortality rate, and maternal mortality rate. So you can pause and then see how much of this you can do in the 10 minutes, and then you can continue to watch the video. Mortality rate speaks to death. Sadly so, we must measure and we must represent what happens even at the point of death. We provide information as to what diseases or conditions are more prevalent among the dead. So we talk about proportionate mortality rate, we talk about case fatality rate, we speak to maternal mortality rate, infant mortality rate. And really it's giving you an understanding of what groups of persons are dying, where they are, what are the particular disease or conditions that are causing this negative outcome of death. It also helps us in the management of diseases. So if we recognize that larger number of persons are dying from this particular illness as opposed to this particular illness, then we now need to refocus our programs or train our resources in terms of human resource, and provide maybe financial resources to stem these conditions. And while we may be able to obtain incidence data, uh, and again, it varies, it depends on the type of illness. Sometimes the data that we collect for mortality rates can be skewed. For example, someone lived with diabetes 20 years, 25 years, but they died in a motor vehicle accident. The death certificate will state death from motor vehicle accident. And so sometimes we lose the information as it relates to the condition that this person may be living with or have lived with over the last 10, 15 years. So there's some skewing of the data. Uh, if it is that this person had a complication from the diabetes and then died, then we could say death due to complications of diabetes. And then we'd get a true recording of the deaths from diabetes. But you can see where we have some blurring of the information and some skewing of the data as it relates to that. So there are some limitations, and that is why sometimes it's indicated that incidence rates or data on incidence is more easily obtained as opposed to that of mortality rates. So let's talk about some types of mortality rates. Infant mortality rate, as is displayed here, it's really representing the deaths in our infants. And infants here are considered to be persons less than 1 year old, we say 0 to 11 months, who would have died. And we are representing this or making reference to all those other persons in that period of time who are born and are born alive. Note it is per the number of live births. And why is that so? We can have total births, which would really encompass live births and stillbirths, and stillbirths are not counted when we are making reference to infant mortality rates. So a quick question for you. In 2003, we had 28,025 infant deaths. We had 4,089,950 children born in that time. I want you to calculate the infant mortality rate. Even though the answer is displayed on the screen, I want you to physically attend to it and to do the calculation on your calculator to verify that this response is actually correct. Another example is given to you. In 1996, total number of infant deaths were 1,988, and the total live births were 59,965. What is your response for the rates, the infant mortality rate in this time? I want you to note that when we are representing rates, we represent them as particular ratings. So if, for example, we represent them as a percentage, in the case of incidence and prevalence, we can represent that as rates per 100, or we can say as a percentage. Then there are other rates that we represent as per 1,000, for example, infant mortality. So when we calculate this number, although we multiply by 1,000, we represent our response to say 33.2 deaths per 1,000 live births. Another mortality rate that we calculate is maternal mortality. And this is really representing the number of persons who would have died. That's the maternal death. So due to some complications of the birth of a child, so it could be related to pregnancy, labor, and delivery. And usually the concept is within 6 weeks post-delivery. If you die in that time, you're considered to have do you represent the total number of maternal deaths. And again, we're comparing that to the total number of live births. And it may seem a bit odd, but that's how it is usually represented. Here, this is represented as per 100,000. So whatever number you'd have gotten, it's the total number. Say, for example, you got 10 maternal deaths. So it's 10 maternal deaths per 100,000 live births. All right, so you can see an example here. Again, you can verify for yourself that this answer is actually so. And if it is, then you can put a comment in the chat to say, yes, it is correct. Case fatality rate is another mortality rate that is calculated. And this is usually used, especially when we have, for example, maybe it could be a pandemic, or it could be just general that we're looking at a particular disease and we want to know how many persons who developed this disease actually died from the disease. So the formula states total number of deaths from a particular disease during a specific time per the total number of persons with that particular disease. So if we want to know about breast cancer, case fatality rate for breast cancer, total number of persons who died from breast cancer, per the total number of persons at this time living with the particular breast cancer. And this is represented by a percentage or as a percentage. Proportionate mortality rate also represented as a percentage. We're looking here now at the total number of persons who died from a particular illness or disease per the total number of persons who died in the population. So yes, we can look at breast cancer. We want to know what's the proportionate mortality rate for breast cancer, but we're comparing that to everyone who would have died in that particular time. So whether it be a motor vehicle accident, a lung cancer, prostate cancer, it could be sudden death from whatever the complications may be, a heart attack, any other cardiovascular disease. It's the total number of deaths for that particular period of time. So we can do that for a period of maybe 3 months. It could be a period of 6 months. It could be a period of a year. It could be over the past 5 years. But we're looking at the number of persons dying from this one particular illness compared to the other deaths in the population. Again, we have another example for you to work through and to compare your answer. Then we have attack rate, and this is many times used when we have an epidemic. We are calculating the number of persons, new cases within a particular population per the total number of persons who are at risk for the disease. So if you're not at risk for the disease, then more than likely we would not have you in the denominator. For example, if we're looking at an infant population, then the total number of persons at risk will be those 0 to 11 months. If we're looking at adolescents, then it will be those persons between age 13 and 19. So that frames the total population at risk and not everybody necessarily in the population. And this is represented by a percentage. If it is though that everybody's at risk, for example, with COVID-19 or even dengue, everybody's at risk. So if you're calculating attack rate, then everybody in that particular population would be in the denominator. Crude birth rate, and we're now looking at crude rates. Those that we looked at earlier were more specific rates. We're looking now at a crude rate. So we have crude birth rate, we can have crude death rate, and crude here really means that everybody is involved. So we have the total number of births in a particular place for every 1,000 or every 100,000 persons in the population. You will note that in some jurisdictions, crude birth rate is represented as per 1,000 or per 100,000. So when you do your calculation, you should verify whether you're using 100,000 or 1,000. Fertility rate speaks to the total number of births among women in the fertile age. And the fertile age, again, can vary by jurisdiction. For example, some texts will tell you 15 to 52. Here in Jamaica, our fertility rate is 15 to 49. So it's the total number of live births in the stated period. Again, we're looking possibly at a particular specific timing, and we are comparing those number of live births to the total population of the women in that particular age group, 15 to 19. All right. While we have an age of consent that may be different and all of that, and we can have 12-year-olds, we'd have had cases of 12-year-olds and 10-year-olds giving birth. But when we're looking at the specifics as it relates to fertility rate, the bandwidth that we have here is age 15 to 49. Of course, those outliers, whether some persons have children over 50 or they may have children less than 15 years. We do have those outliers. And so usually we would make accounts for those. But the question to you now is, as a country develops, the mean age for pregnancy increases and the number of births per woman decreases. How do you think that affects the general development of a country? How do you see that affecting our aging population? How do you see that affecting our workforce? You can put your comments in the chat. Another type of rates, and we did say we have three major types of rates that we will speak to. We have the crude rates, specific rates, and then the adjusted rates. And adjusted rates are really used to help us generally to make comparisons. So we have different adjustments that we can do. We adjust for socioeconomic status, we adjust for age, we can adjust for race, but it's really a calculation that we do to ensure that we are not unfairly making comparison between one group as opposed to the other. So the relevance of age-adjusted rate is evident when we're studying conditions such as cancer, where we have different trends and we have different age groups in different countries who may develop particular cancer. So we may have a younger population in a particular country compared to another country. And so if we should do a comparison without making the adjustments, then we would not be given a true comparison as to what happens in the two countries. Then we have sex-adjusted prevalence of diseases, where we have the confounding variable in sex, male or female. And so again, we must adjust for that to make sure that we're not comparing unnecessarily more males than females. Heart disease prevalence may differ in sex due to biological or lifestyle factors. And so if we're just saying that, oh, we have more males in this population and we just have less females in that population, it would not be a true representation, and hence the need for the adjustments. Continuing to speak to mortality rates, and this really is a summary of what we have spoken about. There's a worksheet that is for you to actually do calculations to get more familiar with these rates and to be able to identify the denominators as opposed to the numerators, to find the limitations as it relates to the denominators and also the numerators. And you can see based on the formula that you would have seen, especially when we think about like a fertility rate or mortality rate, we see that the numerator and the denominator varies. And so when you're looking at a formula, you should not just think about the formula just based on the name or the nomenclature of the formula, but to make an assessment and also to understand what the formula really means. So in terms of crude mortality rate, it's the total number of deaths in a population in a specific time per the total number of persons in the population. And the name suggests crude. Then we have age specific. We have also standardized mortality rate, and that speaks to the adjusted rates. And lastly, we have crude death rates. All right. And again, we're looking at the total population when we speak to crude, whether it be mortality or death rate. But when we speak to specific rates, then we're looking at a subset of the population. So let's just talk about how we present or represent epidemiological data. Based on the type of variable, then you would make the representation. And so to consider here are three types of variables: nominal, ordinal, interval, and ratio. This I'm sure you would have had classes on when you did biostatistics or when you did research methods. And so I won't delve too much into this, but just to remind you of what these are and how we actually utilize things. So in presenting data, we can present it in a nominal form. So we have nominal data. And this data is used to classify or group variables into non-numerical and usually non-numerical ranking. So we are categorizing the data. So we order them in terms of ranking. We are using them to make distinct labels for our groups. So we could consider this to be a qualitative label in terms of the name. So for example, gender, marital status, types of fruits, or it could be the color of your hair. These are really qualitative descriptions in a context where we're describing these groupings or these categories. All right, so we have examples. So you have males and females. You may be in terms of marital status, it could be whether you're single, married, or divorced. All right. Then and this is really in a context for male and female, it's a dichotomy. You're either male or female. All right. If you're asked about a particular illness, you either have the disease or you don't have the disease. If you're in a race, you're either first in the race or second or last, or whatever the number you place. Of course, we do have some times where we have two persons being at first, but again, it's either you're first or you're second. You can't be first and second in the same race. All right, then there's the ordinal data. And again, we are categorizing these as it relates to non-numerical, all right? So it's really ordering, or we are classifying them based on a prescribed description that we would have given. For example, as is displayed on the slide here, we have strongly agree, agreed, neither agree or disagree, disagree, or strongly agree. And you will tick one, and then you will tick whatever that question is asking of you, then you have one response. You can't say that you strongly agree on a point and at the same time disagree. So it's really a dichotomy again. It's either you are or you're not in that context. And so when we look at educational level, while you can have a certificate of completion from high school, you have a bachelor's, you have a master's, you have a doctorate, or whatever the qualification, a certification, etc. If you were asked about ranking your qualification, we usually say, what's your highest level of qualification? So you're not just looking at one, you're not making a response of 2 or 3. So if it is that we needed to make a response of 2 or 3, then the question would be framed differently. But usually when we are using ordinal data, we may ask you, what's your highest level of qualification? If we were asking you about pain, we say on a scale of 1 to 10, how would you rate your pain? Or we can put it in other variables such as moderate, severe, or mild. Then we have what is known as the numerical or the interval data. This represents categories, yes, but then it's more in a natural ranking of the category. So we look at factors such as temperature or dates or your IQ scores or the time of the day, or if you're measuring something, what's the exact measurement that you're giving? 1.2 meters or 1.3 centimeters. It's more of a very specific measuring or measurement that is provided. Importantly, also, we look at racial data. And this, again, is a numeric data. Uh, and it's really, the difference really between that and the interval is that this has no true zero. Interval data may provide for you a true zero, but a racial data may not provide you a true zero figure. All right. So the real number with as it relates to intervals, and we have a zero, meaning the lack of or the absence of in terms of a zero value. While for the ratio data, we really do not have a true zero. So the ratio data, the ratio data has a true zero. Let me correct that. While the interval does not have a true zero figure. All right. So the ratio data, again, has a meaningful or a true 0 point, which represents the absence of the measured quantity, while the interval does not have a true zero. All right. So the last thing I want to talk about in terms of representing epidemiological data is how we present, and this is statistical means in terms of the mode, the frequency, the proportion, median, mean, standard deviation, and variance. So as it relates to the nominal, ordinal, interval, and ratio, we see the nominal, it's names, you're categorizing them based on names. For ordinal, we're really ordering the matter on whether it be out of a scale of 1 to 2, or we can say agree, strongly agree, frequent, most frequent, etc. But we are really ordering the data as it were. For interval now, we have intervals and we have equal intervals. So it's on a scale, you have 1, then 2, then 3, then 4, then 5. While in between that 1 and 2, you can have other measurements in terms of how we graduate a scale. But the intervals are usually equal, and they are known through 0 for the interval ratios, interval measurements. While for ratio, we do have a true 0, and um, that's representing how we can describe data as it relates to categorizing types of data. This is Stephanie from statistics.com. In this video, I'm going to be showing you So in summary, understanding rates and proportions enable us to make decisions. And so by understanding which rates and what proportions we're measuring, we're able to provide data to help to plan health events, plan services that we need, recruit resources that we would need in terms of human resource, develop and implement policies to protect the health of our population. It also helps to stimulate scientific research for further broadening of our understanding. So if we're seeing in our jurisdiction or in our community a certain number of cases of a particular illness, or we're seeing a social behavior that is maladaptive, then we can go out and do a research to find out Why is this happening? How does this occur? And what are the things we can do to stem this particular maladaptive behavior or the disease? Epidemiological data must be presented in a standardized manner. And hence, we do not just go out and just collect data, but when we are even analyzing the data for reporting, then we need to look at what we see. We will probably measure them or compare them to other data, but it's important that once you're collecting data, that you have an instrument that is standardized to begin with, and then also if there's need for adjustments in terms of adjustments or standardization of the data. If you're comparing, for example, race, you're comparing age group, you're comparing socioeconomic status, then there's a further adjustment of the rate that may be necessary. So as we understand or have a better appreciation of mortality and morbidity data and why we collect those, then I believe we should be better able to provide information to our patients, information to our colleagues as it relates to diseases and illnesses and events that we see in our population. These are my references, and thank you for listening. Have a good day and see you in the next video. Just to note, there is an activity here for you to do, and you can do this and just place your comments in the chat. Have a blessed day.